Good evening, everybody. We'll give people a few minutes to join and then we'll get started with this evening's seminar. Alrighty, I think we'll go ahead and get started. Welcome to everyone joining us live and to those watching after the fact. We're very honored this evening to have Dr. Lisa Fortier joining us to present on intra-articular approaches to osteoarthritis. Just our general announcements as usual. So tonight's seminar will be recorded, and this link will be emailed out within about a week of this evening's seminar. If you have questions throughout the presentation, please use the Q&A and we may address some of those during the talk, and we'll save some for after as well. A reminder about our next upcoming seminar, which will be Tuesday, November 19th at 6 p.m. This will be focused on equine behavior and will be with Cornell's Dr. Kate Anderson. Alrighty, I'm going to go ahead and introduce Dr. Fortier. I think we could probably spend over an hour just listing Dr. Fortier's accomplishments, but I'll keep this brief and let her take over. So Dr. Fortier is the James Law Professor of Surgery at Cornell University, and she's also the Chief Publications Officer and Editor-in-Chief at the American Veterinary Medical Association. She received her DVM from Colorado State University in 1991, and then she completed both her surgical residency and a PhD at Cornell University. Over the past 30 years, she has gained an international reputation for really significant contributions in the areas of equine joint disease, cartilage biology, and regenerative medicine, and particularly for her pioneering use of biologics in horses and in humans. Dr. Fortier serves on the Horse Racing Integrity and Safety Authority's Racetrack Safety Standing Committee, and in 2022, Dr. Fortier received an induction into the University of Kentucky Equine Research Hall of Fame, which is a very big deal. We are so pleased to have Dr. Fortier with us tonight, and with that, I will turn it over.
Great, thank you, Kelly, and Lindsay for having me in your equine seminar series. I've loved working with both of you on bringing biologics to your fields of passion as well. As Kelly said, I'm going to talk about intra-articular approaches to osteoarthritis. For the non-veterinarians, intra-articular would simply be a joint injection. So how and why should we think about joint injections for osteoarthritis in our horse? So osteoarthritis might also be spavin in your horse as well. So again, as Kelly said, please feel free to put items in the chat, and I've invited Kelly to interrupt me so you're not getting death by PowerPoint. This might just take a second to move on. Okay. It has to get moving, I guess. Surveys would indicate that 87% of equine veterinarians from all disciplines, no matter what you use your horse for, what kind of veterinarian you are, that they use some biologics of some sort. And that's pretty impressive number when you think about it. So why are we using biologics, and when are we using them, and how are we going to think about it? Why do we inject joints? There's lots of different reasons. We could inject them because there's a perceived source of pain. An owner might say, oh, a little sore over here, or your horse flexes positive to stifle or hock. The animal could be stiff. And these same reasons could go for joint injections in people and dogs as well, or for poor performance. And sometimes you might think, well, it's a sacroiliac or sore in the neck and those sorts of things. We also inject horses not uncommonly for routine maintenance. Once a year, we know that horse has a recurrent issue in a fetlock, a navicular bone, or navicular area, coffin joint, based on radiographic changes sometimes. Effusion, which is also joint swelling, shown here in this picture of the fetlock joint of a horse. You can see that there's some effusion in this joint or joint swelling. And oftentimes, post-operatively, we'll recommend, I'm just going to small this down. There we go. Oftentimes, Vanessa, is that to me?
Sorry, no, not for you.
Okay, thank you. Oftentimes we'll inject joints based on radiographic changes that may or may not have a diagnosis that they're sore in that region. So here are the hock joints of a horse, and this horse has some moderate to advanced spavin. So this may or may not be causing the horse problems, but if we simply take x-rays of a horse's hocks, we might inject it for that reason as well. And I'm not supporting any of these reasons. I'm just trying to get you to think of why do we inject joints with biologics or other things? And what do we use? Most commonly still, unfortunately, most of us still reach for corticosteroids, also known just as steroids. That's easy to do, and they're relatively inexpensive, and we're mostly comfortable with them. What I'm going to hopefully convince you of tonight is that you really want to go more towards the orthobiologics or just biologics. They're also known as ortho, refers to like the musculoskeletal system. So biologics are used everywhere in the body, from hair regrowth to reproductive organs. So ortho just refers to the use of biologics in the musculoskeletal system. And autologous means self. So from that animal, you make the biologic and give it back to that animal. And then more recently, in the last several years, we've really turned a lot of our attention to the polyacrylamide hydrogels, also known as Arthramid. That's what it is in humans, or in animals is Arthramid vet. In humans is Arthrosamid. There's another product called Noltrex that has some other characteristics that are a little bit less enticing than Arthramid. So patient selection is also really, really important. It's not uncommon that we treat a horse with rest and physical therapy, and that doesn't work. So then we go to an injection of steroids, and that doesn't work. So then we go to something else. But if something's not working, we really have to stop and think, are we injecting the right patient at the right time? On the left over here, you see a side view, a medial to lateral radiograph or x-ray of a normal ankle joint in a horse. Here's the cannon bone, proximal or long phalanx, and the sesamoid bone. No signs of osteoarthritis or joint swelling in here. Here's a normal stifle. This is the kneecap or patella up here, the fibula on this side. Nice normal joint space, no signs of bone spurs or osteophytes. This is what normal cartilage looks like, bright, white, shiny. It actually is so smooth, it has a coefficient of friction that is less than glass on glass, or sorry, than ice on ice. So it has a really important function in very easy movement of the joint. And this is what cartilage looks like on a normal histology. This is the surface. It's very, very well ordered cartilage, and then it becomes mineralized cartilage, and then it becomes subchondral bone. So this is what a normal joint looks like. The other thing I'll point out is this is the joint capsule. And you can see how thin it is, and there's just a tiny bit of yellowing over here. In contrast, when you come on this side and we see an arthritic fetlock joint, so you can see a bone spur up here on the top of the sesamoid, some bone roughening over here. This is thick. This is the joint capsule where it's more bright white. That indicates some scar tissue. Same view of a stifle joint where you can see all of these bone spurs or osteophytes. Here's what it would look like under on a gross examination. So this is the surrounding cartilage, wearing of the cartilage down to this mineralized area. And then the loss of chondrocytes. So these empty, these white spots are where the cells used to live, and it's all like shag carpet on the surface. There's nothing that is going to help this animal on the right. So continuing to inject that animal is not in anybody's best interest. So you really need to know from your diagnostics where the animal is in this spectrum from normal to hopeless. So what is being targeted? What is being treated when we put any of these things into a joint, whether it's steroids, biologics, or the polyacrylamide hydrogels? You might think, and you might be told, that it's being put in there to calm the cartilage or rebuild the cartilage. But really what we're targeting is the synovial membrane. The cartilage in a joint has no nerves, no blood supply. So it is a living tissue, but we're really, really targeting the synovial membrane. Again, here's that normal joint, and when you look inside of it, this is the trochlear ridge of the talus and the kneecap up here, and the normal joint capsule on the side. When I look at a joint at surgery, one of the easiest ways to see how healthy the joint is look at the synovial membrane of the joint capsule, and you can literally see blood pulsing through this synovial membrane, this frond of synovial membrane when it's normal. It looks like a sea anemone. In contrast, when you're putting a scope into an arthritic joint, you can see this cartilage fibrillation or fraying, and over here how thick this joint capsule is. On the closer up view, it's really blunted. It's very red. There's no synovial fronds. And we know from many, many areas of research that this is the area that we're targeting, this synovial membrane. And secondarily, we're targeting the cartilage because it's really the synovial membrane that brings in all the synovial fluid, takes away the waste from the cartilage. So this is really the powerhouse of the joint is the synovial membrane, and that's what we're targeting. Not even really the bones or the ligaments. There are some ligaments inside the joint, but primarily our thought should be on how do I target that synovial membrane and what might be the status of that synovial membrane in that joint that I'm injecting. We were taught many years ago that arthritis is not an inflammatory condition, and that is not true. It's been known for many decades that it is an inflammatory condition. It's actually immune mediated. That's not saying it's rheumatoid arthritis, that it is autoimmune, where your body's attacking itself. But we know that there are large numbers of immune cells, both in the normal joint over here, which I'm not going to go over, and then in the inflamed or osteoarthritic cell, we see a shift in all these different types of immune cells, macrophages and immune cells, T cells as well. And they come from the synovial membrane into the joint, and then they have their effect on the articular cartilage. So again, what we're targeting are these cells and the immune system, which is really run by the synovial membrane. The several phases of inflammation in a joint, we know that inflammation happens either acutely, right? You sprain your ankle, you get some inflammation, or you can have an old injury and reactivate that injury, which is called acute on chronic. And so what we're trying to do is go from this normal state. Here's a blood vessel or a hyperemic or engorged synovial membrane, not very happy. We're trying to reverse that back to a normal status so that we get the normal cells in there. These normal 3 phases of inflammation are known in every tissue system, whether you break a bone, a skin incision, or whatever it is, you get these same 3 phases. Inflammation, where you get neutrophils, which are inflammatory. You get the proliferation phase, where macrophages come in, and then you get tissue remodeling, which can occur over years to get that tissue back to where it started. Now, we're not trying, with our joint injections, we're not trying to eliminate any of these phases. It's really important in biology that your body goes through all of these phases, but we're trying really hard not to get stuck in any one phase. So you've all maybe seen or experienced a tendinopathy or another injury where it looks like it's healing pretty well in the beginning, and then it kind of stalls out. So you're either stalling out in this middle phase or this last phase, and what we're trying to figure out and target then with our treatments, where are you stuck? And how could we push you through to the next phase so you can get on to tissue remodeling? Early on, this really great group out of, they were at Kentucky at the time, and many of them have moved on to other areas, but this group had this college athlete population where these athletes injured their cruciate ligament. And they took, at the time of injury, these markers here, they took synovial fluid, so joint fluid out of the knee that was injured, at the time of injury, at the time of surgery, 1 week post-op, and 4 weeks post-op. And what this group was looking for is, what is a biomarker? Because we know if the same surgeon fixed 200 knees, some people heal and some don't. So what is a biomarker to say, why are some healing and some aren't? And at 4 weeks post-op, these groups that went on to be what they called responders, those that went back to athletic performance, had full range of motion, versus non-responders who had chronic problems with the joint and developed some osteoarthritis, they really separated out in their joint fluid by the amount of interleukin-6. There's lots and lots of interleukins, IL-1, IL-6, all kinds of them. IL-6 has been known for a long time as a pro-inflammatory, causing inflammation and perpetuating inflammation in skin disease, in neurodegenerative disease, as well as in musculoskeletal. So it doesn't matter what the number is, what they found the number, but these populations of people segregated at this very clear definitive point into responders or non-responders on IL-6. So that can help us go back and say, okay, this might be a biomarker of a non-responder. Where is IL-6 in that 3 phases of the inflammatory cascade? And then push the patient into the next phase with your treatment. We also know that interleukin-6, when you put it into a joint, causes osteoarthritis. And we know from models of post-traumatic osteoarthritis, so if you rupture the cruciate ligament in a mouse, or there's other models of post-traumatic osteoarthritis that we can study this disease, we know that IL-6 is increased there too. So this is these basketball players were a natural athletic component to support that IL-6 is an important biomarker. What we did in my laboratory a couple of years ago was to take our natural patients with post-traumatic osteoarthritis, and that is the thoroughbred racehorse. So you may or may not know that thoroughbreds, when they're running, gallop on one leg at a time, and they go about 30 miles an hour, so 12 to 1,400 pounds, one leg at a time. And in some horses, at the end of the race, when they are hyperextending or going like this with their fetlock, they'll chip off this little piece of bone on the dorsal medial part of proximal P1 or right here in the ankle joint. We know that if you go in and surgically chip this off, you can induce post-traumatic osteoarthritis. You take it out and the animal reverts back to normal. So what is at play there that you can have this osteoarthritis in the horse, remove that chip, that irritant in the joint, and revert them back to normal? So we took the population of horses that I operated at Cornell and categorized them as mild, moderate, and severe post-traumatic osteoarthritis based on what I saw at surgery. So here's a case of mild. This is distal P1. So this is, sorry, the condyle. So you're looking here. This is the top of P1, and this is where the chip's been removed. So the bone underneath here is really healthy. The surrounding cartilage is normal. Just this small chip has been removed. The synovial membrane up here is looking normal as well. So we took synovial fluid out of this joint. Let's say it's the left front. And we got permission from the owners to also take out synovial fluid from the opposite limb to serve as a control. So the right front ankle, or right front and left front, either way. And then we had several cases that also had moderate post-traumatic arthritis. So here you can see where the chip was removed. This bone is a little more red, not as happy, and the cartilage surrounding the chip is a bit fibrillated as well. So what did we find? We were looking at this population of cells called T cells. In a normal joint, you have these cells called T regulatory cells, and they make the joint healthy. And they secrete interleukin-10, which is a happy cytokine, and they're known, you can identify them by their nuclear transcription factor, FOXP3. This becomes important, I promise. On the other side of that balance, and what you have in a normal joint, is this balance between T regulatory, which are good, and Th17, which you don't really want around. Th17 cells secrete IL-17A, known marker for osteoarthritis, also known in a lot of skin diseases. It's identified by its transcription factor, ROR gamma T. Interestingly, you can induce Tregs to turn into Th17 and activate Th17 by IL-6. So remember that work that I showed you in the human athletes by Christian Latterman, where the IL-6 really deviated them into responders and non-responders. So in our normal joints, this is the balance that we found, and we agreed with that they were very much in balance. In the mild and the moderate post-traumatic osteoarthritis, we saw for the first time in any natural disease this imbalance of these T cells. So there were many, many more Th17 cells that secreted IL-17, and they were completely out of balance, and very few T regulatory or good T cells could be found. In addition, what happened was cells that were supposed to be identified as FOXP3, that's by their transcription factor, underwent what we call phenotypic switching. So they look like they're T regulatory cells, but they're secreting IL-17. They're secreting what the Th17 cells are. So again, when we know this, then we're going to say, okay, how in this situation would we have mild to moderate post-traumatic osteoarthritis? How can we shift those Th17 or these phenotypically switched cells back to T regulatory cells to get back to this normal balance? So what happens in this case is that we want to either shut off IL-6 or IL-17A in order that we can shift that balance back. This is also known for macrophages. And if you remember these phases that I showed you, inflammation, tissue formation, and damage, this is the neutrophil phase, this is the macrophage phase, and this is the T cell phase. So at any phase in this, other than the early inflammation phase where we need to knock out neutrophils, and we probably rarely identify very acute inflammation in the horse. The inflammation happens long before the diagnosis is made. It's not that we miss it. It's just that based on biology, the really, really early inflammation happens a lot earlier. At least in soft tissue injuries, maybe not so much in a broken bone, but most sport horse injuries, we've missed the inflammatory phase. So if we're looking at an animal that has macrophages that are out of balance, we're here in the tissue formation. And again, we can try to shift them over to this happy side of the equation to M2s. Or if we're looking at a T cell imbalance, we're already in the tissue remodeling phase. So just some ways to think about what you're putting into the joint. You need to think about where are you in this phase of tissue repair, because they're not all the same, and therefore you shouldn't be thinking that every treatment will act the same. So what is the goal? The goal, of course, is to get the animal back to performance or less pain. And really what we want to do is immunomodulation of the synovium. We want to get back to those T regulatory cells and the M2 macrophages. There's tons of lotions and potions out there. I don't know any of them. I love Surpass and many of them. External stimulation such as shockwave, laser, and EQ press. I don't know any of them that have been investigated with this very specific goal of shifting the cell type population. Nutrition and supplements. I'm a huge fan of Platinum CJ. I'm not a consultant for any of these groups. These are just things I use in my practice and on my own horse. Steroids, I'll go over. So these I'm not going to go over today, but I wanted to talk a little bit more about steroids and the biologics. So corticosteroids, as I said, are quite commonly used. Probably every veterinarian that has done a joint injection has used corticosteroids, and probably the vast majority of performance horses have had an injection of steroids of some form. What are the pros? They're very potent performance-enhancing drugs, no doubt. There's a reason that the Horse Racing Integrity Safety Assurance, that HISA, has put some very strong restrictions, and so is the FEI, on the use of steroids in performance horses. Some might say they're less expensive. I don't know about that. I think the majority of the bills that are produced by academia or private practitioner veterinarians are your service and your time to do the injection, and as it should be, far less of it is the actual cost of the product that you're using. They're very easy off the shelf, no doubt. They're stable. You can pull them off the shelf and use them. You do need to do a little bit more manipulation to do a biologic. And oftentimes we're honestly treating the client. They'll say, I want, my horse's hocks injected with whatever. And you don't actually have a true diagnosis. Again, it might be little lame on flexion, or you do the hocks or the coffin joints every year. And I'm not saying that's a wrong thing to do, but it's an easy way to justify what you're doing. The cons, of course, that we know they're potent performance-enhancing drugs. We know from Medina Spirit, who then, of course, ended up dying suddenly, tested positive and ended up losing a lot of credibility, returning the money. So they're easy to drug test for. So they definitely have their downside. They have zero joint protective effects, whereas the biologics that I'll talk about do. So corticosteroids do nothing to protect the joint. They definitely decrease inflammation, but that's not the same as protecting a joint. And then don't fool yourself. If any of you have had a steroid injection in your plantar fascia or in your knee or something like that, steroid euphoria is real. We have a saying in veterinary medicine that no animal should die without the benefit of corticosteroids. And that's because it makes them euphoric, and that dog that isn't doing well at all will then go on to eat. So oftentimes if you inject a horse's hocks and they're going great for the next few weeks, and the owner says, well, it kind of wore off, that probably means you had your diagnosis wrong. And the horse just had a little bit of steroid euphoria. we can use this to our advantage, because if the horse is feeling better, then maybe the owner will work the horse and the horse will work better, and then they'll build up those surrounding muscles as well. So it's not all bad. I'm just saying if the effect wears off in a week or two, then you probably had the wrong diagnosis. Oh, the other thing I would say, we have several steroids that are available. Betamethasone and triamcinolone are probably the two most commonly used. Several people still use Depomedrol, but I will tell you, as a surgeon of more than 30, maybe 35 years, I have never saved an animal's life for performance. I've saved an animal's life, but they are lame at the walk if they get an infection after Depomedrol. Depo, by its name, right, sticks around for a long time, but I don't know why that it is so damaging to those joints. And sometimes the infection doesn't show up for a long time. So if you're going to use steroids, I beg you to use betamethasone or triamcinolone and stay away from Depomedrol. We just don't need to use it if you want to have steroids in your toolbox. So, yep, this is real. That's all. So what is better than steroids? Pretty much everything, I would say, and for sure orthobiologics. We have a lot of them, and they're coming on the market more and more frequently. Platelet-rich plasma, or PRP, IRAP, Prostride, bone marrow concentrate, STEM, also known as stromal cells or MSCs, A2M, and polyacrylamide hydrogels. So we'll go through each of those a little bit. What is the advantage of these? They too are off the shelf. Most of these take 10 minutes to make. You can do this on the farm. It's not that hard to do. So they really are off the shelf. In addition to decrease in inflammation, they contain growth factors, and we know that it recruits stem cells. So you are actually protecting the joint and causing tissue regeneration, not just decreasing inflammation. They have no regulatory burden. Because they're developed from or derived from blood, most of them are derived from blood. It was many, many years ago in the human athletic world that they went through this whole regulatory process to say, is this considered blood doping? And it's not. So you can use these and inject joints and not be afraid of regulatory repercussions. The disadvantages is that they're variable. Each animal is different, their nutrition is different, how excited they are is different. So they're highly variable. On the human side, if you want to get a PRP injection, it's all out of pocket. So it's not reimbursed like steroids and other injections are. So it can be a little more spendy for you as a patient. Which one is better and when is it better? Acute versus chronic, tendon versus joint. There's no one answer to this. I would say we have options, which is really great. So I already said that, but this is the most common question I get. Which one is best? Is this new one better than the other ones? Arthritis, tendon, ligament, meniscus, acute versus chronic. How many times do I inject it? What's the volume? What's the dose? This picture up here on the right is my laboratory at Cornell. And these are just a few of the machines that make equine platelet-rich plasma. You can use a hanging bag system. There's many, many different ways to make platelet-rich plasma and bone marrow concentrate, let alone all the other biologics. So to try and convince you that biologics are better than the steroids, we had my colleague sent my laboratory knees, human knees, from humans undergoing total knee replacement or total knee arthroplasty. And what we did in the laboratory was to take what remaining cartilage was in there on the top up here, and then this little insert goes into the well, and on the bottom is the synoviocytes, or those cells from the joint capsule. And what we tested was platelet-rich plasma, also known as ACP in this case, hyaluronic acid, or HA, which is another very common thing we inject joints with, and then betamethasone, which is that steroid I told you about. And then, of course, we have a control, which is our normal media that we treat cells with. So we're looking, we tested the cartilage and the synovia, the cartilage in each of these, and nothing happened. The cells were alive. We tested that as well, but no marker went up, nothing went down. And that's probably because it's arthritic. So cartilage isn't all that responsive anyway, but it also supports what I'm telling you, that it's the joint capsule that we should be targeting. So we found in the synoviocytes, or these cells that are on the bottom, if we treated them with PRP, it increased the amount of hyaluronic acid in this fluid. So when you treat with PRP, you stimulate the cells to secrete more HA, and even HA doesn't do that. We find that if you treat with PRP or HA, both of them decrease the amount of TNF alpha that was secreted. TNF alpha is a well-known marker of pain. So now you're increasing lubrication by increasing HA, decreasing pain. And MMP13 is probably the best known cytokine in cartilage research for degrading cartilage. And we showed that if you treat with PRP, you decrease the amount of MMP3. This is actually in the cells itself. And then HA did not do that either. So when you're treating with a biologic, and never happens with a steroid, you are increasing HA, you're decreasing pain through TNF alpha, and you're decreasing cartilage degradation. Again, the point is biologics are better than steroids, and you're targeting the joint capsule. Then it was like, well, there's all these PRP things. Terralyn McCarroll, who is now in Florida, was in the laboratory for a year, and she did this really cool study and submitted it to a journal, and a reviewer came back and said, you did all this work. We did CBCs, complete blood counts on every PRP that we did, and the starting blood. And the reviewer came back and said, can you do some correlation for us? Because at this time, this is in 2010, so we did this research in 2008. At that time in PRP, it was all about the platelets, and more is better, more is better, more is better. So all these companies were coming out with 4-fold, 8-fold, 28-fold, 56-fold, meaning they can generate a PRP that has 56 times more platelets than the starting blood concentration. And it just was getting a little out of control. So what Terralyn showed was, and I'm just going to break this down into green is good and red is bad. So she showed this positive correlation between platelets and synthesis. So collagen is matrix synthesis, and so is COMP. And she showed a negative correlation between platelets and these degradatory cytokines. In contrast, she showed that white blood cell concentration was negatively correlated with matrix synthesis. So more white blood cells, you actually decrease matrix. It just didn't slow it down, it decreased. It took away matrix, and probably because it increases MMPs. So for the first time, and again, veterinarians, equine veterinary medicine leading in the human world, this conversation shifted from just platelets to, okay, it's not just platelets, the white blood cell concentration is important too, primarily the neutrophils, which is no big surprise. Emily Sundman did the subsequent work to say it wouldn't be any surprise to anybody that we want neutrophils to be removed from PRP. So she looked at, in all these samples of blood and PRP generated by a couple different systems, what's the correlation between interleukin-1, another catabolic or degradatory cytokine, and neutrophils? And there's a pretty strong correlation here. So more IL-1 beta comes from more neutrophils, no surprise. And there's no correlation between IL-1 beta and lymphocytes. Anybody who knows white blood cells wouldn't be surprised by this. Martha Murray's group in Boston went on to further this work and showed that the best, so this work shows that the best kind of PRP is one that you've decreased the amount of white blood cells, specifically neutrophils. Martha Murray, as I was going to say, went on then to show that even better than that, if you can make a PRP that's neutrophil depleted but monocyte enhanced, that's the best PRP. There's no system on the market right now that can actually do that. So importantly, when you're looking at a PRP, what you want to know is that the neutrophils are reduced, because we don't want to put in white blood cells that will decrease the amount of matrix. We're already up against the wall trying to create matrix like tendon. So why use PRP when steroids work? Do steroids work? They certainly decrease pain, but PRP and other biologics are regenerative and anti-inflammatory. There are many, many large studies in people, level 1, meaning randomized double-blinded placebo control, that show that PRP works better and lasts longer than steroids or HA for knee arthritis. It's not a drug. As I told you earlier, it's World Anti-Doping Association approved. It's not blood doping, but it's not a miracle. Again, think of that normal in the continuum of the hopeless case. So if the hopeless case, if steroids aren't working, don't expect PRP to work. So it's not a miracle for sure. And most of the time, in most practices, when I've asked, what do you charge for a PRP injection? What do you charge for a steroid injection? PRP is really only about $25 more than steroids because, as I said, most of the cost is from the veterinarian's time, the reagents that they use, and the injection itself, as it should be. So what is in PRP? Here's a nice little blood smear to share. These are the neutrophils. Here's the little platelets in the background and all the red blood cells. And when you think about PRP, remember all of these things that are in blood are in PRP. But what you're getting, what you do not get with steroids, is matrix synthesis. You do get pain relief with both, but we get cell proliferation through all these different chemokines, cytokines, and growth factors, and new blood vessels as well. As I said, though, all biologics are complicated, whether it's PRP or IRAP or autologous conditioned serum. We think of platelet-rich plasma as platelets and white blood cells, but again, remember where they come from. They come from blood. And same with IRAP, comes from serum. So everything that is in serum, all of these different growth factors are in all of these biologics. So again, just it doesn't really matter in the long term, but just don't hone yourself into that it only contains one thing. How many injections do you need? This is my treatment paradigm. I read the human literature a couple weeks ago, and there's still no consensus. Some think it's 1, some think it's 3, some think it's 2. 2 is better than 1. But this is what I do, whether it's a tendon or an intra-articular injection. I give a first injection, and if I do not get a response of any sort, and what do I mean by a response? A response to me would be a decrease in lameness. If it's a joint, a decrease in effusion or joint swelling. If it's a tendon, I want it to, on ultrasound, that the cross-sectional area and the longitudinal pattern are both improved, and that the animal is less painful to palpation. So if I get no response to the first injection, I don't do a second injection. Either I got the diagnosis wrong, or this horse is in that hopeless case. If I do get a response, let's say I get a 40–50% injection, in about 2 to 4 weeks, I will do a second injection. I'd love to get at these animals within 2 weeks, so we're not entering over into that chronic phase. Remember, we want to keep them and get them through that middle phase a little bit faster. So that's where we're at. And so in about 2 to 4, I try to get patients back or see them in another 2 weeks, full lameness exam with flexions and all of the things, an ultrasound examination. And sometimes, probably half the time, we'll get a second injection. If I don't get an improvement from there, I do not give a third injection. If I do get a response, I might do a third injection. I've probably only done 2 or 3 third injections in my life. It's really 1 or 2 injections and very assertive rehabilitation. I can't emphasize this enough, that putting PRP into a joint or any biologic into a joint and stuffing a horse in the stall or putting it out in the field is not going to get you anywhere. It's really, really on the rehab. This is just one step in the whole program. So rehab on these animals and controlled exercise is super critical. It's only in the last 6 months that we've learned about platelet dose. People have been trying to figure this out for a long time. So that's not volume, right? You can't just say, I gave him 2 mils of PRP, because you need to know how many platelets were in there so that you know what the platelet dose is. And so these are because people believe in leukoreduced, especially for knee arthritis. We don't want to put neutrophils into a joint. So leukoreduced, there's a couple different studies comparing 4 mils versus 8 mils, and you can see the billion of platelets there. And the 8 mils was better. This is a human knee. 8 mils in a human knee is a pretty large volume. So they did suffer occurred some short-term pain and stiffness in the higher volume group. But this 5.6 billion is the same dose that we get with our leukoreduced in the horse. There's a couple different systems that produce it. So we do know that we want around 5 billion platelets. People usually say 5 to 6 billion platelets in a dose. But again, remembering leukoreduced. So this is really cool. This is just in the last, this just came out sometime this year, and there's 2 studies that agree on the platelet dose. And this is the second one. This is a review. Again, it's highly variable, though. If you took 1 vat of blood from 1 horse and divided it into 3 different systems, the same animal won't even make PRP within each system. So it can be frustrating to go through this whole part, and it's just part of all biologics. It doesn't matter if it's PRP or IRAP or ProStride or any of those things. It is just one of the frustrating things about the orthobiologics. The other part is why are they so variable? What is the patient aspect of this? And we're just starting to understand this in the horse. So we know that a short burst of exercise will increase white blood cells. Non-steroidals can impact at the time, taking non-steroidals, not taking non-steroidals afterwards, but taking non-steroidals at the time of the draw. Smoking, as you might imagine, in humans is very bad for their platelets. Some people have a personalized sensitivity in platelet handling and nutrition. All these things are really important, and we're just starting to learn about them in the horse. The second part that we'll talk about is IRAP, orthokine regenokine. It has a lot of different names. It's been available in the horse since 2007. FDA approved since 2007. It's so common. This horse was actually named IRAP, as you can see on its silks here. IRAP is made by incubating blood in this syringe with these glass beads, but it's an overnight incubation, which isn't great, right? If I'm at your farm or you're at the clinic and you want to treat that horse, or if you're an owner and you want your horse treated that day, it's no fun to have to come back or somebody comes out and injects your animal later. Lots of star athletes have gotten this and still get it. So it's still a viable option, but it has the disadvantage of requiring incubation. How it works is this is a molecule interleukin-1 receptor antagonist. So it antagonizes this receptor. It allows it not to work because it replaces where IL-1 should bind. So that also means you need more of the receptor antagonist than you need of the actual IL-1. And that's important when you're looking at these products as well. Again, that overnight incubation, this is not available in humans in America, because this incubation of blood is considered manipulating blood outside of the body, and it's not allowed in human clinics. So this product is not available for humans. So to get around that overnight incubation, along came ProStride. In humans, this will be called N-Stride. What the ProStride system does basically is you put blood in here and spin it, and then with their system of these two buoys, you get platelets and white blood cells. And then those platelets and white blood cells are combined with these polyacrylamide beads. Remember, I told you in the IRAP system, they're glass. Here, they're just polyacrylamide. The white blood cells, very similar to IRAP, they attach to the beads that the monocytes do. The monocytes then secrete interleukin-1 receptor antagonist, or IRAP, and that's how you get more. And the idea of ProStride is that you get this patient side. The disadvantage of ProStride is you get very small volume. And because if you think of the volume expansion, you get a very, very little IRAP. So it can be very expensive too in those cases where you would like to treat 2 stifles and 2 coffins, or both coffins, or both fetlocks, or something like that. So here's just a small breakdown. You can see it's an order of magnitude more expensive on a picogram level of IRAP. If you have multiple joints and you want to use IRAP, then still go with the old IRAP system, or there's another one called ProEase as well. And I'm not against ProStride, don't get me wrong. It's just, it's hard for me to justify that small volume for not as much IRAP as you would like to get. And if you really, really want to use IRAP, if that's your favorite molecule of choice, then you should probably be using bone marrow concentrate. Jen Casano, who's at UC Davis now, did this very cool study in using bone marrow and bone marrow concentrate. And we looked at all these different cytokines and chemokines and growth factors that were in bone marrow concentrate based on a panel. We didn't pick to look at IL-1RA. Nobody thought to look for IL-1RA or IRAP in bone marrow concentrate. But you can see here, this is bone marrow aspirate, 2 different kinds of bone marrow concentrate. Remember, I showed you all those machines, so you can use those same machines to generate bone marrow concentrate. So you take 60 cc's of bone marrow from the horse, concentrate it down. And then we also had whole blood, or venous blood, regular blood, and platelet-rich plasma. And here's the amount of IRAP in these items. The pink is if you were to take blood and incubate it overnight and make regular old IRAP. And the blue line is how much IRAP on a picogram per mil you have with prostride. So if you really want to get bone marrow concentrate, or sorry, interleukin-1 receptor antagonist or IRAP, then use bone marrow concentrate, or even just plain bone marrow aspirate has more IRAP than either blood or PRP or prostride. So as I said, to make bone marrow concentrate, you go where the girth goes in the horse, simply right here. I've done, I don't know, thousands of these, and there's only one horse I've not been able to do this and without any consequences. And that was a horse that kept lifting up her front feet. And she would, as she lifted up her front feet, she would hit this syringe, and underneath here is the heart. So that's a bad thing to do. We couldn't hold up a leg. She would jump out. Very clever horse. So that was the only horse I was never able to do this for. Here's a cross section of the horse's sternum, which lies in here. So you're really going for these couple sternobra. Very safe procedure. And as I said, you use the same machine. This would be making platelet-rich plasma. Here's the platelets sit down here, and here's the bone marrow concentrate. The idea with bone marrow concentrate, we talk about tissue regeneration, and there's this idea that there's this trilogy. So in order to get this full tissue regeneration, you want to provide cells and a scaffold and these biophysical signals or growth factors. So we know from bone marrow concentrate that we're delivering mesenchymal stromal cells. We know that there's a scaffold, which is also in platelet-rich plasma, and that we're delivering these growth factors. And platelet-rich plasma would have both the scaffold and these growth factors, cytokines and chemokines, but you don't deliver the cells like bone marrow concentrate does. Further, bone marrow concentrate allows these MSCs or stromal cells to stay within their native environment, what's also called their niche. And we know that when cells stay in their niche and they're not removed from their native environment, that they're more functional in the way that they're intended to. So how do we think MSCs work? Let me see what we used to think was MSCs, when they were delivered to, let's say, a joint, that they integrated into the cartilage and turned into cartilage, or they turned into tendon. At least that's what we used to say. That has been shown to not be true for decades. How we know that stem cells work is they secrete all these different molecules. And they, again, here comes back to that word immunomodulation. So they help macrophages become the good macrophages. All these T cells that we talked about earlier, turning them into the good T cells. We also know that these same secretome, so these are just secreted by the MSC. So this is their whole secretome. They recruit more MSCs to the site, and they bring in more blood vessels. So again, it's fine if you want to believe that those MSCs are, if that's an easy way to think of it, that they are rebuilding the tissue, but they aren't doing it themselves. It's the secretome and the effects of the secretome that are really rebuilding the tissue. So again, we know that you have these cells, these MSCs in their niche, cells get activated. So tissue cells get injured, they get activated. The MSCs sit quiescently or inactive in every tissue that you have in your body. They get activated and they secrete all of these things, go on to immunomodulation, recruit, and angiogenesis. We also know that when you look at, many people think monocytes are the MSCs, and there's several manuscripts to support this. And if you look at the number of monocytes that are in PRP, you get a 0.3, and in bone marrow concentrate, you get an order of magnitude more. So again, coming back to the idea that we either want to deliver cells or recruit more cells to the site, specifically MSCs, and bone marrow concentrate wins out there as well. As a surgeon, when I first started it, we developed bone marrow concentrate at Cornell for the use in articular cartilage repair. And this went on to be used in humans again. So just really proud of the equine profession for leading in tissue regeneration, orthobiologics in several human fields. And this was used to repair articular cartilage. This is a stifle cyst in a horse being repaired. But then Hannah Holmes did this study to show that PRP over here recruits stem cells. So this is called the Biddy chamber. And in the middle, this is time-lapse microscopy. In the middle are mesenchymal stem cells. On this side is platelet-rich plasma, and over here is platelet-derived growth factor, which is a well-known chemokine, so cells should migrate over there. And they don't have to go anywhere. They're not overcrowded in the middle. There's plenty of food. But you can see from this plot that the green is the PRP, and the cells go in a directed and very intentional migration towards PRP. And they do migrate, but they kind of bounce around over to PDGF. They do the same thing. The same plot could be made for bone marrow concentrate, but it is harder to make. So after we developed at Cornell the way to repair cartilage with bone marrow concentrate, but then I saw this and I went on to think, okay, well, let's use PRP. But then, so we use PRP in the femoral condyle. But then we went on to say, well, how many stem cells do you need? And we really don't know the answer to that. Nobody knows how many cells you need, but we know that bone marrow concentrate delivers about 40,000 MSCs, and importantly, it has that IRAP in it. So lots of different things in bone marrow concentrate that PRP can't deliver. I'm going to go over this a little bit faster because I'm close to out of time and I want time for questions. This secretome that I talked about, right, this puff of stuff that comes out of the MSCs, is not the MSC that rebuilds the tissue, but that is the MSCs or the secretome. And it's really important that people be aware that there are no FDA-approved secretome, extracellular vesicle, or exosome products that are FDA-approved. There are a couple exosome products on the market that the FDA is allowing that company to test, but that does not mean they're FDA approved, which means they have a safety and an efficacy profile. So that's really important for you as a human patient. If somebody's trying to sell you exosomes, or you're being asked to use them in your patients, you need to be able to see them on transmission electron microscopy. These are bilipid membranes. It's not just important that you see them and say we isolated them. Are they biologically active? And if they are in clinical trials, they should have both these IND and IRB numbers. So if you ask those questions, and if they don't know the answer to them, they haven't even filed it with the FDA. I just wanted to go over the polyacrylamide hydrogels, and then we just have a few minutes left. So there's two products available right now in America. And I'm not a consultant for either one of these. The thing that bothers me a little bit about Noltrex, which a lot of people use, is I don't know that it's made in a GMP facility, good manufacturing process. Both of these companies, Noltrex and Arthrimid, are doing a lot of research to try and prove that these are modulating, that they modulate the joint and they're not just decreasing pain, because we don't want something in any of our patients that just decrease pain if they're not actually modulating the joint. So we don't want to mask pain and cause further injury. So we know that these are incorporated into the synovial membrane, and this is a real paradigm shift. So when I first looked at these polyacrylamide hydrogels, I'm all about the synovial membrane, and these incorporate into the synovial membrane and stay there, which is really disconcerting if you think of what normal synovium looks like on histology. So this is normal. That's 1 to 2 cells thick. You can see all this, we call this loose areolar connective tissue underneath here. So this is a very normal synovial membrane. And this is what happens when it is incorporated, and it's incorporated forever. But it's a total paradigm shift in how you think about it and what these cells are. They're starting to show that these are the good macrophages, and that this really goes from like a compressed sponge and opens it up and allows the joint capsule to be more flexible, so less painful. Again, a really big paradigm shift. I primarily use this in coffin joints and in stifled joints post-operatively if I know there is an issue. And I know several people, a couple local practitioners who've started using Arthrimid as a first-line injection for even hawks before they do steroids or anything else. So keep your eye out for Arthrimid and Noltrex as well. As I said, a very assertive rehabilitation program. There's no reason to operate a horse if the owner doesn't want to send the horse to a rehab program and doesn't have the time to do this afterwards. I usually give the owner 2 weeks of exercise rehab to do, and then come back and we'll reassess lameness, ultrasound, whatever it is. But these animals need weight-bearing exercise in order to really heal these tissues. So again, we have options. Treat as early as possible. I can't emphasize enough for every disease in the horse that don't let your horse get fat. Don't even let them get chubby. I have a horse that I struggle with getting chubby. Biomechanics are critically important from the foot. Make sure your farrier and your veterinarian work together to align mechanics. And then case selection. If it's too late, it's too late. And I'll stop there. Oh, I should have stopped sharing screen. Stop sharing. Oh, you took it away. You took it back. Awesome.
That was fantastic. Thank you so much, Dr. Fortier. I'm sure we'll have some questions rolling in here. In the meantime, I have a question, which is aside from an obviously sick horse, are there any kind of concurrent health conditions that would preclude you from wanting to use a horse's own biologics like platelet-rich plasma or stem cells for intra-articular use in that particular patient?
Yeah, we don't know yet, Kelly. You know, the whole patient side aspect, I think we're going to learn so much more. I wouldn't anticipate that metabolic horses are not the best case to use. We do know that a short burst of exercise will increase white blood cells in the horse as well. So obviously trailering can be stressful to them as well. So, you know, letting them calm down, but we don't know enough yet. Sick, as you said, is very important. But metabolic would be another instance.
Excellent. Thank you for that. Yeah, that's something I think about too in treating eyes. We often use a horse's own serum or plasma to treat infected ulcers and that kind of thing. And horses with Cushing's disease, you know, some of the other older horses, we do question, should we be using their own serum plasma or potentially getting from a donor? Another question, for older horses who are no longer, you know, athletes, but are kind of pasture pets, that kind of thing, anything you would recommend for them? I know a lot of older horses live on systemic non-steroidal anti-inflammatories like Equiox. Is that obviously good for their pain? Is that damaging to their joints? Would you avoid that and just use supplements, or is that okay for longer term use in the older horses?
It seems to be pretty safe. I was skeptical about Equiox, and so many, I mean, a lot of animals were on bute for a long time too. I think that also is a very individual, you know, if you ask the four of us that are on panel, Vanessa, Kelly, Lisa, and Lindsay, like I can eat my body weight every day in ibuprofen and it doesn't bother me. And other people get, you know, upset stomach. So we don't know so much about that patient side. For those horses, you know, I'm a huge believer in keep them moving. And I think owners often like, oh, my horse is a little bit sore, I'm going to box stall them. Like they need to be out and moving around.
Yeah, that makes a lot of sense. And the rehab program that you shared in one of your final slides, is that something that you use in each of your kind of post-injection horses? Would that be, you know, somewhat applicable for those older horses as well?
Post-injection and post-op, and even before surgery, I try to prehab them. So let's look at your nutrition. You know, you only need what you need. Not every horse needs, most horses I would contend don't need grain. A ration balancer in our areas, you know, check vitamin E and selenium. And then I'm not a sponsor or consultant either, but I love like or musculoskeletal platinum performance CJ. You know, they do a lot of testing as well. But so many horses are over supplemented with, you know, lots of different things that can cause behavioral problems too. So prehabbing them and keeping them moving and thinking about, you need to keep those muscles to support those joints. And then at surgery and post-op as well. I would say I was on a webinar earlier today, and I thought I was assertive with rehab. This person, even was using these. This is a rehab specialist, and she's using these. There's two types of boots now available that will limit range of motion of a fetlock. So what she's doing now is for a tendinopathy or like a suspensory branch, she's actually having horses trot in the first, it might only be like 10 seconds, but with that boot on, then they're getting the strain in the tendon without the full range of motion. And then the boot comes off, or they can be turned out with a boot so you're not getting further injury. But they do want some full range of motion, but they also want higher strain to get that tendon to heal. So that day of sticking a horse in a box stall or just turning the horse out, I hope is long over.
Yeah, that makes a lot of sense. A couple more questions. Would intra-articular steroid use preclude subsequent use of a biologic? And if not, what kind of time frame between the two would you want? How soon after a steroid can you put a biologic into a joint?
Equine vets are the worst and the best at polypharmacy. There's no right answer to that, whether it's arthrimid or a biologic or a stem cell. I think many of us, when you see, if you believe the data, if you believe the research that says PRP, for example, works better and longer than steroids, then take the time. If you have the proper diagnosis, then take the time and do the biologic injection rather than steroids that are going to wear off, steroids that test positive, steroids that have deleterious effects. But many of us combine all of those things at the same time. There's a recently, I've only seen the abstract of it, but a study showing that it's okay to use betamethasone and arthrimid at the same time, and other studies are coming out too. So we're never going to stop equine vets from doing polypharmacy, and then on top of it, shockwave and all the other things. So there's actually no way to even answer that question. I don't think there's a downside to doing steroids and biologics, but biologics alone are probably sufficient.
Awesome. That's good to know. We do have a few more questions. We're just at a little past 7 now, but I think these should be quick, so we'll wrap up on a few more. There's a question about Tildren. Do you use it? Do you recommend it?
I have never used Tildren. I think the evidence is very strong that it has lots of negative consequences, and it lasts way longer than we think it does. And it is known to decrease pain. So some people, and it just, what most people don't think about how it works, right? It decreases osteoclasts, cells that take away bone. So why, if you have a sclerotic fetlock or a sclerotic navicular bone, why would you give something that stops bone remodeling? If you're stopping one side of it, you're stopping the other. So if you have a bone disease, why are you giving something that stops bone remodeling? So I have actually never used Tildren. I've never seen an instance where I'd want to.
Got it. And just to clarify, correct me if I'm wrong, Lisa, Tildren is a systemically administered drug. It's not intra-articular, correct? It's intramuscular. Is that
Correct.
so?
I think it
Potential
can be
side
given
effects
IV
beyond,
as well.
okay. But potential for side effects just beyond the joints as well, since it's a systemic medication.
Yeah, Heidi Riesink is doing a lot of work relating Tildren to catastrophic failure in racehorses as well.
A lot of thank yous for your talk. And one more question. You spoke a lot about PRP. Have you tried a product called platelet lysate? If yes, what is your opinion about the response?
Yeah, yes, it's even requires even more manipulation than PRP. So, and people used to think, oh, you need to lyse, you do need, the platelets need to be lysed to release their growth factors. But the thing about platelets is anytime they see a tissue, so you put them in the joint, they see cartilage, they see the joint membrane, the platelets are going to be released. You put them into a tendon, you put it into a uterus, it's going to see tissue, and those platelets are going to release all their goodies. So there's no reason to be in the laboratory and cause lysis of the platelets and get platelet releasate.
Got it. That makes sense. We have one last minute question here. And this may be a horse dependent thing. Is your first choice for injecting an arthritic joint PRP or arthrimid?
It's a great question. It's a really great question. Personally, I was just talking with a couple other friends about this. Personally, what I do is to use a leukoreduced platelet-rich plasma and follow it up with arthrimid. They still think arthrimid takes anywhere, again, horse dependent and disease state dependent, probably more than anything for all these discussions. But most people still think arthrimid takes a couple months to have a clinical effect. So what I would do, this is what I do for my own horse, inject with a leukoreduced for a joint, platelet-rich plasma, and then, you want to wait around a few days to be sure you didn't get a flare or anything, and come back 5, 6, 7 days later and put your arthrimid into the joint. Every veterinarian has a little bit different on what their comfort zone is, 10 days, but I've never seen an infection with PRP or any biologic. It usually happens the next day, maybe 24 hours later, unlike, as I said, about betamethasone, which can be weeks later.
Awesome. Well, thank you again, Dr. Fortier, for the amazing presentation and answering all of our questions. We will see everyone next month. Have a good evening.
Thanks for having me.
Wonderful.
Thank you.